A speaker who is a graduate of our program. So I am very excited to introduce Susie, who was a certified registered nurse and
anesthetist
and the former chief nurse anesthetist at Reston Anesthesia Associates in Reston, Virginia. She's from Western Pennsylvania, and she got her BSN at the University of Pittsburgh and her anesthesia degree at the Altoona Hospital School of Anesthesia. She most recently graduated from Penn State World Campus in 2017 with a master's degree in Homeland Security, Public Health Preparedness. She's a contributing author for the Village Project, which deals with human trafficking. She is a guest speaker for Penn State. And also, as of Tuesday, she is a new grandma again.
Number 5.
And tonight she is going to be speaking on the Strategic National Stockpile and how it was used during COVID. So Susie, thank you so much for speaking with us tonight. And I'll turn it over to you.
Okay. Thank you for asking me to be here. I spoke about the Strategic National Stockpile back in August with Alexander had one of his executive seminars, and he had asked me to speak there. So I tweaked it a little bit with, at the time, COVID was just starting to really blossom. Who knew we'd be still where we are right now? So I'll give you a little bit of background on the Strategic National Stockpile, and then I'll get into things that happened that got us to the point where we were back in January, February, March with the shortage of supplies and nationwide and everything that went along with that. So just to begin, a little bit of background, the Strategic National Stockpile is a fairly new endeavor. In 1999, Congress tasked the Health and Human Services and the CDC to establish what they called the National Pharmaceutical Stockpile. It initially had about a $50 million budget, and the initial goal of that was to prepare the country against potential agents such as anthrax, botulism, hemorrhagic fevers, and plague. There are approximately 200 federal and contract employees that are responsible for performing the year-round inventory to sustain the supply and ensure that the meds and all these supplies do not go past the expiration dates. The stockpile has 5 branches: logistics, program planning and analysis, response, scientific oversight, and community resilience. One of the original components that still exists today, because the stockpile has gone through multiple changes, but one of the ones that is still there today are the 12-hour push packs. And these are located across the country, and they contain prepackaged drugs and chemical antidotes and antibiotics that would be used for an emergency. And they, the goal of this is that they could be deployed within 12 hours of a federal decision. The National Stockpile itself is not in one location. It also is in 12 secret locations across the country in these innocuous looking 4 to 5 story warehouses. So it is not one central location. With the stockpile, the deployment of assets occurs when the state governors or their designated officials request deployment of resources when there has been an overt event that will harm the public, such as a terrorist attack or an epidemiological event like COVID that we've been dealing with. It is not meant to be and was never meant to be used as a first line of defense or a first line response tool for anybody. It is to be used when state, local, and private stock of medical materials are in danger of being depleted. Many states have their own stockpiles that can be used, and in order to use them, they need to get permission from the FDA and the CDC. Prior to the Trump administration, and I'll touch on this a little bit more later, but prior to that administration, once a state's resources ran out, they could request it from the national stockpile. Items could then be deployed under order of the Secretary to Homeland Security or the Secretary of Health and Human Services. Each state has its own established plan to receive and distribute the resources. And then this responsibility falls onto the states for the unpacking, storage, and the distribution once an authorized signature was put in place. If the Strategic National Stockpile does not have an item that is needed, then it then uses the Veterans Administration to buy and deliver the products from the private sector. Excuse me for my raspy voice. I woke up this morning with a sore throat, so I'm trying to not be raspy so much. So I apologize for the clearing in my throat. So the National Pharmaceutical Stockpile, it was first used in 9/11 right after the attacks on the Twin Towers. And it was used to get the medical supplies to the first responders. And then shortly after that, it was used that same year when we had the anthrax attacks. In 2003, the stockpile was transferred to the Department of Homeland Security. And at that point, it was then became the National Strategic Stockpile. And that was in order to shift the focus away from just having pharmaceuticals. Since then, it has been utilized mostly for natural disasters, most notably Katrina. But it was also used for the H1N1 outbreak, the Ebola, and the Zika outbreaks. Another resource that was developed when the CDC and the SNS established was the Cities Readiness Initiative. Excuse me. This is a multi-agency project that was developed to build a comprehensive strategy to ensure that cities have a coordinated response plan in effect to have the capacity to offer antibiotics and mechanical ventilators. At the beginning of COVID, that was the big headlines everywhere, was the ventilator shortage. We all know that they are critical as far as a life-saving airway management. And as such, they are included in the CDC stockpiles. In 2002, funding was given to supply the stockpile with 4,000 ventilators. In late 2009, the CDC funded for more, but a problem occurred, and I'll talk about this again later, and that order ended up never being fulfilled. Prior to COVID, hospitals across the nation at the time have about approximately 160,000 ventilators. This is nationwide. And this also includes pediatric ventilators. But out of those 160,000, approximately 75% of those are used on a daily basis with ICU patients, operating rooms, and critical care situations. In times of public health emergencies, the healthcare partners can request ventilators from the stockpile, but then when that emergency is over, then the stockpile gets those ventilators back into their warehouses. So just going to throw some numbers out here. I know people aren't normally a fan of numbers, so I'm just going to throw a couple of them out here. The stockpile currently holds about $8 billion worth of supplies over approximately 900 separate line items. Since its beginning in 1999, it has seen multiple fluctuations in funding. It started out, like I said earlier, with about a $50 million budget at the time of its inception. And then post 9/11 in 2001, that funding jumped up to $900 million. This was then followed by steep drops in 2003 that went way down to $300 million. Excuse me, I need a drink. I apologize. By 2017, it was up to $575 million, and it stayed somewhere in that area for a couple of years. But even during those times, this is where a lot of the depletions occurred during the stockpiles because of hurricanes, and there were multiple wildfires, and there were continued budget cuts. In the budgets in both 2019 and 2020, the Trump administration requested another $102 million in these cuts. Likewise, at this same time, the CDC's Public Health Emergency Preparedness Fund growth went from $939 million in 2003 down to $650 million in 2020. From what I could find, the 2021 budget, they're looking at to keep the SNS funding to be around $700 million. Another change that occurred in 2019 was that the stockpile was transferred yet again, and it now falls under the Office of the Assistant Secretary for Preparedness and Response. And this was done in an effort to streamline procurement for medical countermeasures. So with that little bit of background there, just get into a little bit about how we got to the point where we were January, February, March last year when it became apparent that there were shortages. First of all, in a sign that hospital administrations really could not imagine the magnitude of something like the COVID-19. There was a study done in 2018, and of all the hospitals that were part of this survey, 86% of hospital administrators told the HHS Inspector General that they felt that they were prepared for an infectious outbreak. At that time, they were more focused on terrorist attacks, mostly bioterrorism. So there really wasn't a big focus on emergency infectious diseases back in 2018, as far as the hospital administrator goes. Also, in 2006, funding became available for the CDC to buy 104 million N95 masks and 52 million basic masks for that year. That was specifically to go to the strategic stockpile. The purchase was made, and most of those were distributed in the 2009 flu epidemic, but then none of them were replaced. So there was a shortage already from the 2009. Some of the institutions did restock after the swine flu in 2009, but a problem that occurred then was that nobody was following up to check expiration dates and to really pay attention to the stock. So when the masks were needed for the pandemic, they were old and out of date, and the elastic was brittle and broken, and many of them couldn't be used for anything. So not only were the expiration dates not being checked, but the stock weren't, so they didn't have enough of them to go around for anybody. The hospital where I worked at Reston, once this became apparent that everything was going to be needed, they went through their stockpile that they had at the hospital, and the majority of everything there was outdated and had already expired. So when you look back at 2009 and the flu pandemic, which should have been a dry run for something of a major magnitude, it ended up not being a dry run because there were no significant changes made in order to replenish the stockpile. Another reason why we ran into some trouble at the beginning of last year was that there was no urgency to restock, since it had been several years since anything was needed on a large scale. Hospitals were slashing inventory to increase profits, and a lot of them were using inventory tracking software in the hopes that if they needed supplies, then they would be able to get them as they needed them. Likewise, manufacturers, after they increased production for the swine flu epidemic, they ended up getting stuck with products after the need had passed, and they did not want to build back emergency supplies because they were stuck with all of that. So at the time, the market went overseas. In 2009, approximately 30% of the N95s were made overseas, as well as 90% of the surgical masks. Also, the government was more focused on preparing for terrorism than they were about an epidemiological disaster, more specifically the bioterrorism. So even after the 2002 SARS outbreak and the resurgence of the avian flu, the swine flu outbreak of 2009, the MERS outbreak, and the 2014 Ebola outbreak, the government still lacked a permanent budget to buy protective gear to restock the strategic national stockpile. In 2012, a nonprofit agency surveyed hospitals with CDC funding about how many masks that they had on hand. Less than half of these hospitals said that they had any sort of a stockpile at all. The majority of the hospitals that did have a stockpile felt that they had enough emergency supplies that would get them through a period of around 2 to 4 weeks. Again, even though there were public officials out there just waiting for something of great magnitude to happen, the majority of the hospitals across the United States that were surveyed, they only had enough supplies for 2 to 4 weeks. And here we are 15, 16 months into this pandemic already. So there were further studies done in 2014. And at that point, the CDC was meeting with officials from 10 US manufacturers to discuss the data they were getting about the shortages of protective gear across the nation. At that time, even the most conservative scenario for a pandemic, it was noted that the US would need 1.7 billion to 3.5 billion N95s. And in the worst case scenario, up to 7.3 billion of N95s were going to be needed. But because these companies ended up losing money after the SARS outbreak and the flu outbreak, none of them wanted to be in a position of losing money again. So once more, there was no increase in the production of any emergency protective equipment. And finally, the Trump administration changed up the Health and Human Services Department's main emergency preparedness agency back in 2019. Part of this change cut out multiple groups that were focused on protective gear and emergency supplies, and it also removed a small planned budget that was there in order to buy respiratory masks that were to be replaced back into the national stockpile. So that's a little bit of the problems that occurred before the pandemic that that were just leading into why we had such shortages that we did. So what happened when COVID looked like it was really real, and it was turning into this real pandemic. A few things that occurred in the early months really put us on the wrong path to be able to handle this. The manufacturers, hospital, and the government all lost critical time due to a disarray of the protective equipment supply chain. Hospitals and public officials ended up rationing equipment as they were scrounging for more, and they were this put them in competing with the federal government in order to find emergency supplies. The US manufacturers prior to COVID were making approximately 50 million N95 masks per month. And as we all know now, this ended up being one of the most crucial pieces of equipment that was needed for this pandemic. By June of 2020, the production was supposed to be increased to 80 million a month, but that still fell far short from the estimated 300 million that the Health and Human Services Department said in March of last year that would be needed each month for this pandemic nationwide. In January, when the virus was erupting in China, the Commerce Department had manufacturers ship nearly $18 million worth of PPE to China. This happened in January and in February. And this constituted a more than 1,000% increase in the amount that was shipped over to China in the previous year for the same months. So at that time, the focus still wasn't on the US, it was on focusing on other countries instead of what our own needs were going to be. Also in late January, as the hospitals were becoming more concerned, they tried without success to buy more PPE, but at that time, suppliers started limiting supply so that people or corporations and hospitals could not hoard any of the equipment. And without the federal coordination, manufacturers then began to take actions on their own, and they themselves decided to ramp up the production of PPE. As I said, we used to get most of our masks from China, and with the infections stemming from China, the masks that we used to get from there were stopped for two reasons. One, because China needed them themselves because of the pandemic in their country. And also a lot of the production factories where the US were getting their masks were in the vicinity of Wuhan, and that whole area was quarantined. So they were not producing masks to be sent out. In February, Health and Human Services said the stockpile had 30 million basic masks, but only 12 million of the N95s. And of those 12 million, after checking them, 5 million of those were past the expiration dates. Also in February, this is when former President Trump replaced HHS Secretary Alex Azar with Vice President Pence. And with this changing of the guard, this caused a lot of confusion and a disconnect with many of the states. And this led to decision-making and looking for supplies even more difficult because that chain of command was changed. I'm sure you all remember the daily headlines about the ventilator shortages, especially in New York City when this first started. They were asking for, I believe 100,000 ventilators. And again, there was still a shortage in the stockpile. Back in 2008, then President Bush, that administration launched a project to stockpile ventilators for the pandemic. And then in 2009, the Obama administration had a contract with a California company that was to provide 40,000 ventilators for the Strategic National Stockpile. But in 2014, that company withdrew from that contract, and they had not even produced one ventilator to put into the SNS. And it took the FDA another 5 years to come up with a design that everybody agreed on for a ventilator before an order was placed. So nothing was done until December of 2019 as far as trying to replenish the ventilators in the stockpile. So a whole 10 years went by before there was any real work done to get the ventilators put back into the Strategic National Stockpile. As a result of this long delay then, as I said earlier, the US had about 160,000 ventilators nationwide, including pediatric ones, and the majorities were already in use on a daily basis. At the time of the outbreak, it was estimated that the US was going to need about 700,000 ventilators. Excuse me. The one thing here about the ventilator numbers, I read multiple articles and could not get an exact number of the ventilators. It ranged anywhere from the US had 100,000 ventilators nationwide to the 160,000 ventilators nationwide. And anywhere the numbers for the stockpile was anywhere from 8,000 to 12,000 ventilators in the stockpile. Still far less than what the projected 700,000 number that they were giving out. And through all of this, even at the beginning of this pandemic, there was still no continued support for the Strategic National Stockpile. These lack of support included having unrealistic expectations that it was going to be able to fix it all and give everybody everything that they needed. This was not going to be done for multiple reasons, but one, because of the continued funding cuts that occurred right before the pandemic. There's a lack of timely decisions regarding the emergency supply chains. And also in April 2020, the federal government altered the mission statement of the Strategic National Stockpile during this global epidemic. The statement used to be that supplies were dispensed when, quote, state, local, tribal, and territorial responders request federal assistance to support their response effort. After this change was placed in April 2020, instead of the mission statement explaining how states could request access to the stockpile in an emergency, the website was changed to state that its role is to, quote, supplement state and local supplies during a public health emergency. So this change caused problems for those states that do not have their own stockpile and had in the past relied solely on the Strategic National Stockpile for medical supplies and countermeasures when they needed them. So by this time in February 2020, it became apparent that there were major issues with the supply chain and the availability of what was going to be needed for the emergency necessities. At this point, this is when FEMA started shipping ventilators and the respiratory mask, but some states at the beginning, notably New York and Oregon, each of these states said that they had only received about 10% of what they had requested. And of this 10%, many of the supplies, again, were past the expiration date. The masks, even though they were past the expiration dates, like I said earlier, like the cords could be like dry rotted and you couldn't get a good fit. And that had the fear of you were inhaling all the droplets. So, but even though these masks, they could be used for treating COVID patients, they could not be used anywhere where you would have a sterile environment, like in the operating room. And depending what was going on in the ICU and the patient care, a lot of those were in the sterile areas also. The expired masks had a failure rate of 5 to 10%. So this again added to the fear of all the frontline and first responders that they were dealing with faulty emergency equipment. And the ventilator scare was so bad. Just one example, there was a hospital in Oregon that ended up borrowing a ventilator from a veterinary clinic that was 350 miles away. That was the only ventilator that this hospital could get because it was a small hospital and they had none to begin with. So with, with no clear direction from the federal government, states just started getting supplies from wherever they were able to get them. It was, everybody was like just out for themselves. By March 17th, the HHS said it had deployed more than 333 tons of cargo to support state needs for PPE, such as masks and gowns. At that point, the administration said that it had intended to purchase 500 million N95 masks over the next 18 months for the Strategic National Stockpile. At that time, it also assigned an additional 175 employees to staff the operational center and partnered with 35 private industry members for medical supply chain delivery. As I said earlier, a lot of states did maintain their own stockpiles, and those supplies were able to be used with permission from the FDA and the CDC, but Health and Human Services does not track those supplies. Once state resources run out, then state officials, and this usually falls to the governor, they could put in a request to HHS. If the request is permitted, then the supplies are shipped to the state health officials for distribution. But with the change in the mission statement that occurred last April, and not all states having their own stockpile, so this really disrupted the supply chain in a lot of the states that did not have their own supplies. Another example with the hospitals that having no ventilators, there were places, Washington County, Kansas, it had 2 hospitals, neither hospital had a ventilator between them. So they were struggling to find equipment since they could no longer depend on the Strategic National Stockpile as they had been able to do in the past. So even as of March, the supplies were still very slow in coming. The state of Arizona received 25% of what it had initially requested. Massachusetts requested 750,000 N95 masks, and that was on March 5th. By March 24th, they still had not received any of those. It was at this point that state attorneys from the hardest hit states wrote a letter to the president expressing their urgent needs. Because of this, there was fierce competition among states for all of these supplies, and this led to a lot of confusion between the state and the federal government, which made getting these supplies a lot more difficult. Colorado had asked for 10,000 ventilators, and when the request went unfulfilled, the state ended up buying 500 ventilators from a private vendor. But when these 500 ventilators showed up in Colorado, the FEMA used its authority to jump in front of the line, and it took the ventilators to stock the Strategic National Stockpile. So Colorado still did not get the ventilators that they had procured. And this is happening across the nation, and it was causing delays in getting emergency equipment where it was mostly needed. Here in Virginia, the Secretary of Public Safety and Homeland Security tried working with FEMA, but at that time they wanted 7 days of data before they would even consider a request for more PPE. After receiving less than 200,000 of the requested 3.5 million masks, the leaders of Virginia then started to pursue other medical supply groups to get the supplies on their own, which is what so many of the other states were doing. Several states formed a consortium to band together to procure what they needed without competing against each other. And I think this was happening in the New England area, and I believe out on the Pacific West Coast with Washington, Oregon, California, when they were trying to just work together and just steer clear of the federal government and try to do all of this on their own. But while they were doing this, and they were trying to purchase their own protective equipment, then the manufacturers started price gouging. One company offered to sell New York City $45 million of N95 respirators, and this was a markup of 500 to 600% of what they would normally charge them in other years. Not long after this, at the end of March, a report from the Inspector General's office done based on 324 hospitals and networks said that equipment from federal government fell far short than what was needed and was frequently not being able to use or was of very low quality. One hospital received 2 shipments from FEMA with protective gear that had expired in 2010. Another facility received 1,000 masks from FEMA, and half of them were pediatric masks, so they cannot be used on adult patients or adult staff members. Other administrators had staff out looking at art stores and auto stores and anywhere they could in order to get more gloves and masks for their staff to be able to use. Another thing that was in short supply was the diagnostic testing kits. They were very hard to come by, and because of this limited the ability to monitor patients and also staff members. There were incomplete test kits. They were missing nasal swabs, and a lot of them were missing the agents that were used to detect the virus. Global competition for these testing kits turned into a national competition among federal, state, and local authorities. As the inadequacy of the strategic national stockpile became clearer, lower levels were left to fend for themselves. Maryland's governor was able to procure 500,000 tests, but he got them from South Korea. But when he did this affected the Emergency Management Assistance Compact, which is a mutual aid agreement between states. And again, this turned into a fierce competition for supplies. This shortage of tests nationwide resulted in delays in getting test results, which in turn strained hospital capacity even more. Because even if a patient came in with symptoms and they were tested, even if they didn't have it, that patient was still there waiting until they got the test results, and that tied up a bed and it tied up a staff, and it ended up using more of the protective equipment that was in short supply. We talked about ventilators a lot. That ended up being one of the biggest challenges, but not just the challenge of getting the ventilator itself. The hospital still needed the people that were able to manage the ventilators, more respiratory therapists, more doctors and nurses that were proficient in intensive care and critical care, managing ventilators. So it wasn't just the actual ventilators shortage, there was also a shortage of the staff that was needed to be able to care for all of these COVID patients. And there was another study at this time that showed the hospital chiefs wanted the federal government to offer guidelines on how to handle the ethical decision and issues about deciding who receives the resources and the possible legal liabilities for the doctors who make these decisions. One of the papers I had to do, it wasn't for your class, Jen, it was for somebody else's, I believe. With Hurricane Katrina, there ended up being a court case where I believe it was a doctor and 2 nurses were charged with giving overdoses of fentanyl to patients that they were unable to evacuate from the hospitals. And I believe it ended up, they weren't criminally charged, and it the last that I had read at the time, there were some civil cases that were filed against them also, but it brought up this whole a whole new dimension that we haven't had to deal with before about the legal and ethical decisions on who's going to get this ventilator, who's going to get this drug, and who's going to get this care. So at that point, the administrations were asking the federal government to step in and give them some guidelines on how to handle this. So that's one of that just brings up some of the challenges that the frontline and first responders had to deal with. At the time when for the whole ventilator thing, I know I keep going back to ventilators, but I'm anesthesia, so that was kind of my thing. The FDA had granted an emergency use authorization for modifications of a host of different airway devices that were permitted to be used during the pandemic. This allowed for new, unvetted, and non-traditional sources for equipment, such as using BiPAP and CPAP instead of a ventilator, and using one ventilator, rigging it up so that it was breathing for 2 people and not 1 person. So you had to relearn everything and learn new techniques on how to handle this and how to handle the patient care for these new dynamics and new equipment that was being used. The hospital administrations and personnel, as I mentioned before about the price gouging, they all had to deal with that. I have friends that work in multiple hospitals across the country, and I had seen them on Facebook begging for gloves, begging for face shields and masks, and anything in the areas that were not hard hit to be sent back this way on the East Coast in order to help them out. The hospitals were transforming operating rooms into COVID units. They were transporting patients through the hallways, trying to earmark, special places for COVID patients. They were turning regular recovery rooms into COVID units. So all of this, all the staff had to be taught new skills. Everybody was learning a new skill set. Where I worked, because the OR cases were slow, we were only doing emergency cases. There was no elective cases, so the census in the OR was down. So they were taking the surgical techs and sending them up into the ICUs and critical care to help with the proning, which was one of the things that came out with turning these COVID patients prone onto their stomach in order to get better lung capacities and to help improve their breathing. So everybody was learning a new skill set, and this caused a lot of stress among a lot of people. The PPE store shortage resulted in many hospitals making the mandate that you get 1 N95 mask per week, and it could be recycled 6 times. And this occurred where I was. My one anesthesiologist friend's little girl decorated paper bags for everybody, because then that way everybody had their own paper bag to put their mask in that they had to use every week, every day for the week. People were wrapping face shields in saran wrap, and then when you were done taking care of that patient, you threw that saran wrap away and you rewrapped your mask with more saran wrap. I know if you're like me, I'm on Facebook a lot, and people put those Walmartian pictures up there so you could see some of the crazy ideas that people were using for protective equipment just being out in public in the grocery stores. But that wasn't too far from the truth, because there were people in the hospital using garbage bags and duct tape to use as protective gear when the gowns ran out. There were people that were cutting 2-liter Coke bottles apart and using that clear plastic as a face shield. I saw a lot of people were trying to find swim goggles to use as eye protection. So there was a lot of ingenuity that you had to come up with, but it also added another level of stress trying to protect yourself and protect your patient and other staff members and your family, since there was such a huge shortage of the protective equipment. And along with that, there were no extra scrubs. A lot of the hospitals, I know in the OR, our scrubs were provided for us. A lot of the intensive care units, they were provided by the hospital and then taken care of by a laundry service. And this wasn't happening. So you had the added stress of taking your scrub clothes home or changing in the hospital, and then the fear of exposing your family to your contaminated scrub clothes. I have a friend who works at Howard Hospital in DC. She's also a nurse anesthetist, and she ended up being part of an intubation team, which was a team that was working 24-hour shifts, and they were responsible for doing all the intubations on all the COVID patients that were coming in. She has a husband who had a kidney transplant, and she had 2 young children. And she called me one night crying. She didn't know what to do. because she was terrified of taking COVID home to her husband who had had a transplant and her kids. So she had to make the decision, should she stay in a hotel and not see her family? She did try that for a while, but then it just got to be too bad with her kids. So she ended up deciding to go home, but she said every night it was pulling into the garage, getting undressed in the garage, putting everything in a plastic bag so they could go right into the washing machine, taking a shower before she could even say hello to her little kids. And this was night after night. And this is something that tens and thousands of healthcare workers were dealing with across the nation with this. Again, because a lot of it, there was just not enough protective equipment to make this any easier on anybody. And I mentioned the mental health issues, and just talking about my friend now that worked at Howard. Not so much, there was the fear of infecting your family, your coworkers and other patients, but it was also working longer shifts. There was the sensory and information overload. Like every couple of hours, there was something else on the news or on a website that different ICUs were trying, like the proning, and trying the different drug cocktails. So there was just this sensory overload of all this information coming in that you're responsible in a way for just trying to just like soak it all in so that you were aware of what was going on. And in anesthesia, with intubations, we are right there in front of the face. And we were trying to work with engineering to do different things with the anesthesia machines. We now have COVID specific anesthesia machines. There were 2 of them that are separate from regular use in the OR, but trying to come up with different ways to protect the anesthesia provider and anybody else in the room. One of the things was the West Virginia University, somebody came up with these things called these intubation boxes, which was just clear plastic of like 20 inches by 20 inches by 20 inches clear, so that when you're intubating, you know, your face is right next to this person, and they normally, if you're not in a controlled center, controlled situation where the patient is paralyzed, there's a lot of coughing and the spewing of the droplets. So with this plastic shield there, we were still able to see what we were doing, but if the patient was coughing, then that plastic shield helped protect everybody else in the room from having those droplets being sprayed up into your face. So just those are just some of the things that people had to deal with, and just the fact that being in healthcare, frontline responders, first responders, no matter what aspect or what area you work within healthcare, you are taught to heal and make people better. And so many of these people were dying and they weren't getting better. And it was that feeling of powerlessness that caused a lot of anxiety and depression among a lot of the healthcare workers and first line responders. And it's still going like that since we are, like I said, 15 months into that. And even though things are slowing down and getting better, there are still people dealing with a lot of issues that were related to this. So in hindsight, what can we take from some of these shortfalls that we encountered in the past year, year and a half with this? Number one, there was a new public-private program developed known as the Dynamic Ventilator Reserve. This will be used to facilitate redeployment of ventilators and vent supplies to areas of need. It will have a virtual ventilator inventory and will be managed jointly by FEMA and the American Hospital Association in conjunction with different healthcare systems. The community mitigation response needs to improve. I don't know how we do that. Even with all the scientific evidence out there, this turned into being a very divisive time. But there's more public education needs to be addressed when we have these when we have a pandemic or something to this this magnitude. Something else that was implemented last year was that there is now a request put in for the Strategic National Stockpile to obtain 500,095 masks, and they are to be on hand at all time and ready to go. In June of last year, in 2020, a government panel testified about the shortages in supplies in the equipment and services that occurred so far during this pandemic. The witnesses highlighted the global competition for supplies and the inadequacies of the Strategic National Stockpile. As a result of this hearing, 4 recommendations were made that focus on the stockpiling, the supply chain, and the decision-making process to improve our nation's preparedness and response capabilities. The first recommendation was to re-examine the concept itself of the Strategic National Stockpile. The pandemic showed that the actual use of the stockpile was a significant departure from planning, doctrine, and exercises, and it left a lot of states to fend for themselves, as well as causing a loss of confidence in the federal government. A new stockpile concept should be stress tested and optimized through training exercises. It was suggested at this hearing that a new mission statement be codified in law that will signal the capabilities of the Strategic National Stockpile, and it won't be subject to the whims of any future administrations. The second recommendation is to develop a strategic national supply chain. This approach is to aim to have complete independence from the global market for the production of critical supplies and equipment. Under this, then, each healthcare system would need to have a larger cushion of emergency supplies and be more diligent about checking supply levels and expiration dates, which would allow them to have more control over their own resources. The third proposal was to increase public health funding. I had touched briefly earlier about all the budget cuts that happened year in and year out. But this panel communicated that they felt that public health should be considered a national security issue, and as such, they should receive similar priorities such as the DoD and the intel communities get. The public health shortages, which resulted from budget cuts, severely hampered preparedness and response to the COVID-19. Staff support, essential equipment, supply chains, and the biosurveillance activities, which included the contact tracing, are just a few of the shortfalls that adversely affected the CDC, FEMA, and the NIH since the beginning of this pandemic. The goal should be to reestablish U.S. leadership in global public health. And the fourth recommendation was to develop a vaccine distribution system. Now, as I said, this hearing took place in June of last year, so it was before we obviously got to the point now where we have the vaccines. But what we know now is that in December of 2020 is when the FDA issued the first emergency use authorization for the Pfizer vaccine. The CDC's advisory committee then released recommendations for the priority immunizations and developed the phase structure that I'm sure we're all aware of now. Each state more or less followed these dosing guidelines, and it depended on the vaccine supply. Health officials began to enlist regional and supermarket pharmacies ahead of schedule in order to address delays when this vaccine rollout was to occur. In December of last year, the goal was to vaccinate 20 million people just in December alone. At that time, the stockpile had only 15 million syringes in its entire stock. The government then placed orders to increase that number to 500 million syringes to get us into the beginning stages of the vaccine rollout. It was also determined that the stockpile would have, they would start making vaccine kits, and in these kits, it would have a needle, syringe, alcohol wipe, Band-Aid, and these would also be shipped out with all of when the vaccines were shipped out. One of the drug companies, Becton Dickinson, which we all see at BD when it's written on anything, they are right now working to supply the stockpile with 286 million syringes that are supposed to be there by midsummer. The vaccines themselves are shipped directly to each state or large urban areas, and the Strategic National Stockpile is now to act only as a supplementary source for this. U.S. Marshals were to be stationed at all state stockpile facilities to protect the storage, the transport, and the receiving of the vaccines. I'm sure after this pandemic declines, there's going to be multiple hearings to discuss what went right, what went wrong, the efficacy of the stockpile, the efficacy of the vaccine rollout. But since we're still going through this, I'll be interested to read some of the reports that come out later on. I think we should expect to see more events like COVIDs, especially since we have seen all these variants coming out in other countries and are now here in the US. I think it has become apparent that in any future discussions that we have about our nation's preparedness, that the strategic national stockpile, it needs to be featured prominently in these discussions, because as we have seen, it failed in what we needed to be done here with the beginning of this pandemic. So that's all I have. Can I apologize for my throat? Anybody have any comments?
Thank you so much, Susie. That was really great. I really appreciated all of that information.
Sorry.
So, no. We'll let you catch your breath. So I'm gonna open it up. I've got the chat open. So if you want to unmute and ask Susie a question, you can go ahead and do that. Or if you want to type it in and I can read it. So either way.
I was just curious if there's a plan to rotate the supplies in the strategic national stockpile to avoid the expiration issues that they had. Seems like it was kind of created, stocked, and then never touched again instead of rotating it.
Yeah, I didn't read anything about rotating supplies, just that, as I said at the beginning, they have like approximately 200 employees, and their job is solely to check the expiration dates and to check the stock. So I think right there at the beginning, I think that was like an epic failure, because somebody was obviously not doing the job that they were specifically put there to do, to have so many things outdated, like 10 years ago. Like I said, some of the masks they were dated in 2010, expired in 2010. So there's been a big lapse in that aspect of it, just right off of the start.
Susie, this was great. Thanks. A really fascinating insight into that whole thing.
Thank you.
So I guess so I think I heard today the WHO is just establishing a pandemic center in Berlin now. And so their job is to partly is to do modeling and such and look for the outbreaks coming. Seems like that would be an important function of the stockpile as well. Because of not only the occurrence, but also where it's occurring and where it may be occurring. So whose responsibility is it to do that sort of modeling and predicting, and then moving supplies or buying supplies or whatever? Does that fall with?
It falls down under the office of the assistant secretary to HHS. That's where it falls under now, and along with CDC and FEMA.
So that seems more in line than with stockpile. It seems in line with stockpile organization then too. Is that correct?
Yes.
Yeah. Okay. Well, that would be, yeah, that would be good.
And that changes the funding too, because it was it was under the Department of Homeland Security. So I mean, and I read pages and pages trying to find this on the yearly budgets. So the budget cuts and how much money goes to it, it also depends on what jurisdiction it is falling under, and it has changed 3 times already. So that has a factor playing in how much funding that they get also.
And I may have missed this, but so what percentage of the states have a stockpile of their own?
I couldn't find how many states had it. It just said that several states, and I did look this up. I don't have an answer to that one. But they said a lot of the poorer states and they mentioned some of them in like the southwestern US, in the middle, like Kansas. Kansas was one of them that they don't have the funding to maintain their own stockpiles. So they were the ones that were relying solely on the strategic national stockpile when they needed it in times of like the tornadoes and natural disasters.
I'm sure those states that do have them, it's all distributed in different places too, under different, whether it's emergency management or health or whomever it's within.
Yeah, and they have to get the okay even to distribute it from their own state stockpiles.
Right.
Hey, Susie, this is Mark.
Hi, Mark.
Hey, I'm just curious, and I know on the SNS warehouses, the locations for obvious reasons are not disclosed, but I'm wondering and this is just a question for the group, I wonder if FEMA is organized into regions, as you know, it's broken into regions as far as how they're managed. I'm just wondering if the SNS follows the same model as FEMA does in terms of organizing their warehouse locations under a regional model where each regional administrator can coordinate utilization of or pulling resources from those warehouses at the regional level. Does that make sense?
I know what you say. I don't have an answer to that. I live right outside of DC, and I can't tell you how many inconspicuous looking 4 to 5 story boxes I see that I wonder, all right, come on, I'm right out 15 miles out of DC. One of these is holding something.
It seemed like coordination wise, and you touched on this with Maryland's example, you know, the governor under EMAC agreements, it sounds like state to state coordination. Obviously there's hoarding of supplies and so forth going on, but more what I'm thinking about in terms of improvement would be maybe detailing some of the people from the state emergency agencies to these warehouses so they're familiar with what's on hand, maybe even doing some stock rotation and so forth, so that we're not in a crisis and all of a sudden trying to rely on things and we don't even have any knowledge. You know, that would be something at the state level. State would have to coordinate, trying to get involved in a lot of that. But you touched on a lot of really good things from a provider standpoint. And I wanted to add some things about the masks. And one of the problems with the masks and the supply chain disruption and so forth is there's a huge potential for counterfeiting. And as you know, there's a lot of companies that are pushing out products that are substandard. And I think that kind of tied in with problems with healthcare providers in terms of also having problems getting fit tested, products being pushed out, you're not fit tested, but you're expected to use them and so on and so forth. So that's an issue. Anyway, I'm going to mute myself because there's audio in the background, but we'll talk about that. The other thing was commercialization of services that are deconning masks. A lot of mentioned one mask for 6 days. There are a lot of people that are having to reuse masks and possibly sending them out to vendors to sterilize them. Those, that was going on a lot.
That's still going on at Reston.
Yeah,
still going on 15 months out.
The mask you may get in return may not be the one that was on your face originally, which is kind of disgusting. But I mean, that's a lot of what's going on.
Yeah, I spend more time with coworkers and family, so.
Exactly, but all good stuff. Thank you.
Thank you. I want to look into. I think Kelly, I don't know which one you mentioned about if the supplies are rotated. Since it's obvious that people are failing miserably at checking the expiration dates, but for my own benefit now, I didn't think of that. So something I'm going to look into, because now I want to know, how do they know? I'm asking myself these questions now. If one state stockpile has all this stuff expired, do they pull from another one? So that's something. Thank you. When I'm still awake at 3 a.m., I'll be looking into that now. But you brought up a very interesting point I didn't think of, but now I'm curious about it.
Well, thank you. If you find out,
I'll let Jen know, and she can let everybody else know. That'll be my homework, because I know I'll still be up at 2 o'clock. So that'll be something I can look at other than Amazon shopping.
Well, I was curious because in my own hospital, one of the things that they did was, for their pandemic preparedness plan, they actually prepared by using or having PAPRs available. So they can, they had the PAPRs, but they realized because of the supply chain disruption that they didn't have the consumables that you need with the PAPRs, and they didn't have N95 masks on stock for the pandemic.
What hospital? Where are you? What state?
I'm in Pennsylvania.
Well, I grew up in Pennsylvania. I was born there, so I have a lot of stories from my former coworkers in Pennsylvania. Also, I keep in touch with a lot of people, and Pennsylvania was very hard hit. Most of my family is still there.
Oh,
but yeah, the supply chain. Yeah, you'd have one piece of equipment, but even like our anesthesia machines, we were trying to add another set of tubing. It's like a filtering system, but like we would have one part, but we wouldn't have the mask to go with it. So every little piece in the supply chain, that it just caused so much angst, like trying to find, you're like, okay, this idea is going to work, but oh, we only have this part, but we can't get this part. So it was things that I never thought about before were really brought to the forefront with this. That it really makes me, I've always appreciated military. My family's military, my son-in-law is military, but when I think of the medics and how they have to be MacGyver and just make things work with what they have, it just, like, my respect even went 100-fold, just trying to piece together things for an anesthesia machine in a hospital. But I can't imagine, how they have to piece things together where they are. Anybody else?
Sorry, I have one more question, but it's more about your diverse background. I was looking at it. You were speaking on SNS. You're a CRNA, and you're an author on human trafficking. So how did all of those come about?
Health reasons and plan B. So I had to recently retire. That's why it says former chief nurse anesthetist. Health reasons have prevented me from finishing out my career in anesthesia. And I knew this a couple of years ago. So my plan B was to get a master's in Homeland Security. And I live outside of DC, maybe get a job, but then I saw what having no clearance and no prior experience will get me nowhere. So then I just started, networking, friends of friends. My son-in-law's military, he's in Intel. So he knew this gentleman who we work with at Intel who starts this village project, which is in human trafficking. So I wrote articles how we in the medical field can recognize human trafficking. And I still keep in touch with Alexander, and he put me back in touch with Jen, who was my instructor. So it's just networking. So now I'm trying to get into I went back also at Penn State and got my online graduate teaching certificate. So I'm trying to keep myself busy since physically I can't anymore. So I'm trying to make my brain cells work a little bit better. So that's my diverse background. It's health related. So I plan B, C, and D I'm trying to work on right now.
It's interesting that you have the human trafficking in there as well, because I keep saying that in 410, I always find people who mention that as something that they're interested in. And then a few months ago, we had somebody who I used to serve with in the Coast Guard. He works for DHS HSI, and he did a webinar for us on human trafficking. And I just didn't. I worked with a woman who did her MPH capstone in human trafficking. So it's something that just keeps coming back and coming back. So
yeah, especially the area where we live here too. It's we have 395, 495, 270. We have a lot of highways here to a lot of different places. So just a lot of things interest me with the Homeland Security. I wish I could have top security clearance and know the good stuff, but since I can't, I'm just piecing away where I can.
So I know it's a little bit after 9 o'clock, so I don't want to keep everybody too long. Does anybody have any more questions for Susie? I don't see anything in the chat, and I don't see anybody unmuting. So thank you so much again. We really appreciate you coming and speaking. I know it's been a crazy week for you, so I really appreciate you taking your time to come talk to us.
No, thank you for asking me. You're my second Zoom presentation, so thank you for putting up with me with that. I'm learning. You're my learning curve.
We would have never known that. We would have never known it at all.
But I appreciate your attention and the questions, and thank you so much for asking me.
Thank you. So
right.
anybody who wants to come to the IAEM meeting, we'll see you third Wednesday.